Hello, everybody. This is Mark Kwan coming at you from Bice Institute, Vancouver, Canada. It's Friday, and for those who are joining us live on Friday, we know you're the true fan. So we welcome you. Today is episode 10. David, is it episode 10 today? Yeah, episode 10. Yes, 10th episode already. Thank you so much for celebrating our 20-year anniversary of Bice Institute. We do have a very special guest today. A special friend all the way coming from Calgary, Canada, Dr. Ahmed Keshkool. Let's welcome Dr. Keshkool here. There you go.
Thank you, Mark,
He and
for the
I,
invite.
yeah.
It's my pleasure to be here with you.
We had I know time difference is only 1 hour, but you travel long yesterday, because you finish your work and you're coming here.
Yeah, exactly.
And then you had a bit of a sleep and get up early again to help us with the lecture, right?
For my presentation this
That's
morning.
right.
Yeah.
That's right. And then we just finished, had a little meal.
Yeah.
Because Dr. Bernard Jin's birthday, we did a little birthday party for Dr. Jin. We had a good meal, and we're just having a cup of tea, and we're going to have this talk show, right? Yeah. Thank you so much for joining us.
Thank you for having me.
Yeah, absolutely. We got doctors joining us, and we got some of our faculty members also joining us from here. And we have Dr. Michael Unti, joining us all the way from Chicago. Thank you, Michael. Appreciate it. So, Dr. Keshkool, okay. Dr. Ahmed.
Whatever works. Even Dr. K.
Yeah, there you go. There you go.
Whatever easier for
you. Like I've known you for a long time.
Yeah.
And so a lot of our faculty known you for a long time. But a lot of other members, like our beginning members, may have heard of you, of course, but they might not know you. Tell us about a little bit of yourself. Where you were born, raised, when you came here. Where you studied. How long you've been dentist for. A little bit of that. Give us a little bit of backstory, would you?
Kind of. Yeah, so my story started in 1994 when I finished my faculty of dentistry back home in Iraq. And then since then, I went to UK to finish my postgraduate study in the Royal College of Physicians and Surgeons of Glasgow. And I finished my fellowship. Then after that, I went back home and I appointed as the Dean of the Faculty of Dentistry back home in my city. In my small city, there was a university which has all the medical specialty, which is the Faculty of Medicine, Faculty of Pharmacy and Nursing, but no dentistry. And then I've been asked, can we establish a Faculty of Dentistry? And then since then, I've been appointed there and start from scratch, from the paperwork to the staff, even to the style and what we have to do with the logo, everything. I put myself in every details.
Yeah.
And then I became the Dean of the Faculty.
Which year was this?
That's between 2010 and 14.
Oh, wow.
During that time, back and forth, I was also with the family here because my family in Canada.
They were here before you were here?
Yeah, so, and then it's a commitment. And then I came here, joined them later, and then, finish my work there, quit, come here to Canada to join them, and then finish my, accreditation program, and then become a dentist here.
So you have to pass the board here?
Oh, yeah.
Oh, so 2014, you came to Canada. When did we first met then? Because it was a few years after that then, right?
Our first meeting was in 2016.
Calgary.
In Calgary. So that was a PR, of course. Now, actual course with you was that 2018. That's the immediate anterior.
Oh, anterior
That's
course.
when
anterior course.
you blow my mind and you talk. I remember when he's talking about, what do you know about immediate anterior? I said, oh yeah, we know. I said, you know Jack. And since then, I know that Jack. I recognize what is Jack because I just mentioned in the morning, there is dental implant and there is anterior dental implant. That's the beast. Okay, it's totally different story. Since then, I joined Bites. It's my honor. And then 2019, I joined Bites as a faculty member. And
I remember you took that course, and then you took all my advanced courses. You you followed me to Toronto.
Yes.
You took the advanced courses. And then you became part of our faculty, and you helped us with module 5, which is a guided surgery.
Yeah.
Lecture portion of that. Yeah, and helped the doctor with the hands-on portion as well. Yeah, so it's so good to have you.
Thank you.
Absolutely. Yeah, I remember that.
It's my honor and pleasure.
Yeah. It's always great to be reminded that Bison Institute for me, you know, it started 20 years ago. But when I look back and I think, then it brings me back to memories, and I cannot thank enough to Bytes. Even though I created it, I'm also grateful to it because it became something that I didn't expect it to be.
Exactly.
Yeah, I started with such a local small study club, 5 people, and then it grown into something that I never really expected. And most important part is it has given me and us the opportunity to meet, you know, and like Bernard, you know, like Michael, Jeff, Albert Louis, and his daughter, and Neki, and Hoyoung, and all these people that have come and, you know, taken my courses and our courses and all this. Because at the end, I think the biggest reward for me is a friends that I've got to meet great people who always encourage me and inspire me, including yourself. So it's such a nice. It was funny, like, and Ahmed said, "Oh, so Mark, let's know what do we talk about? It's alive, you know, like, you know, what should we talk about?" I say, you know, it doesn't matter, Ahmed. It's our talk. It's a moment for us to reflect.
Yeah.
On, because sometimes you and I, we both live such a busy life. Sometimes we're so busy that sometimes we don't have the opportunity to look back and kind of enjoy what has, you know, became, right? So, you know, unless we have a moment like this, you know, because it forces us to reflect back, right? Yeah, so I think that's a wonderful thing. That's a wonderful thing. Right?
Yeah, and we all owe you to bright the path for us to take this journey with you. Honestly, it's an honor and to share all this information because we all dentists and we are sharing experience with each other. We learn from each other. We learn from our mistakes. That's why we post always in Bytes and sharing information with the dentists and with each other. And sometimes even privately we text each other, what do you think about this case? What do you think about this case?
Yeah. Tell me, like, besides implant dentistry is your passion, you're into domino. Today I was listening to a lecture there. What's this domino thing? I never thought you was a domino guy. How did that start?
Oh yeah, I love domino because kind of it's in our tradition to play domino. We play it in a team of 4, and every Friday I go with my friend. I like it because you keep...
Is that a cultural thing, your thing?
It's everywhere, but I think that in Spain this is very popular.
I heard that in Spain, yes, it is.
It's very popular, but we love it. And why I like it? Because it keeps you thinking always, and keep your brain is just working fine, because it's kind of it's a challenging game, as thinking game, and you have to support your teammate. How it's a strategy game. It's kind of a chess, but it's a domino. So that's our habit. It's our Friday. So our wife can't argue with us because that's our main thing.
And you've been doing this for how long? Every Friday?
Many years.
Many years.
Many years. It's a commitment.
How many hours?
4 to 5.
Oh, 1 hour?
No, 4 to 5 hours.
4 to 5 hours.
Sit together.
And is it evening thing, midnight thing, overnight thing? What is it?
It's evening, it's evening after 7.
Oh, wow.
Yeah, spend that time. So drinking together, like exchanging jokes, and then have fun. And on the same time, we are playing the domino.
Is that right?
Yeah. That's one of the hobbies, by the way. Because I play soccer twice a week. I play tennis every week. Yeah. And
this is all after work?
Of course.
After work?
After work, yeah. It's a commitment.
You know that. It's commitment.
Yeah, just keep yourself active because we are working hard. So
good for you. While I'm staying after work treatment planning with Kevin, he's playing soccer and tennis. That's good for you, man.
I try to finish my treatment planning before I leave the office.
Awesome, man. Awesome. Good job. You're also going to Spain?
Next week.
Next week.
Oh,
That was a surprise.
yeah. I'm going with my
Play
friends.
domino? Domino tournament?
No. We are going to watch the Clásico between Real Madrid and Barcelona. I'm a Real Madrid fan, a big fan. So
Real Madrid, that's a matchup.
yeah. So we're gonna watch the Clásico in Spain, in Madrid.
Wonderful.
So,
Wonderful.
Yeah.
Good for you.
Yeah.
How did you get the tickets?
so hard. Yeah, don't know about it. It's kind of as hard as Taylor Swift.
That's what I'm saying. Taylor Swift. That's just as hard.
Exactly, is that right?
Did your daughter get the Taylor Swift ticket?
No, she was looking at. She's desperate to have the Taylor Swift ticket. We couldn't. We
God,
tried
it's sold
Toronto.
out.
We tried Vancouver. It's sold out. You get in the queue of 30 million people, and with a lottery chance. So
Oh, it's like harder to attend Taylor Swift than
Exactly.
attend the Olympic seat, right?
it's just 1,000 ticket available or 2,000 tickets, and the waiting of 30 million people. So there is no way.
What am I missing?
Yeah,
You know,
exactly.
Taylor Swift.
I just recognize that you have a talent of singing. So you should switch.
Not at the Taylor Swift level. Okay, yeah, all right, maybe we'll see. We'll see.
We'll
Okay.
find out.
Yeah, we'll find out. Very interesting. You know, sometimes like I've been known like Ahmed for so long, but it's kind of enlightening. And like domino, you know, only domino game that I know. Me and my daughter, my 7-year-old, we line things up, we push it, domino effect.
That's it. Domino effect.
That was a domino game. Awesome. Tonight's lecture, you know what? I've hosted a lot of 20th anniversary with a lot of our faculty, title, but that is the most interesting title. How to mitigate, right? Oxidative stress.
It's a new term, is that right?
Yeah.
We're
It's
using.
Mitigate is almost like a legal terminology. Oxidative sounds so scientific, okay? So tell us about this title. You know, how did you come up with this title? What this topic? Obviously, when I asked my faculty to come up with a 15-minute presentation, they come up with a presentation that they have a special affinity for, something that is meaningful, something that you only get 15 minutes. So it's something that you want to share, right? It's not something that just in any clinical case, but it's something that is meaningful to each and one of us. And you particularly chose this topic. And I know you as a person, you're not just going to pick any topic. And this is a title that to be honest, intrigued me the most. So tell us about the motivation for this topic.
Yeah, so I had a lot of trouble opening a flap, like in oral surgery, like in GBR and dental implant. And sometimes I found that early opening or like the closure of the flap is not perfect. Bone resorption, and everyone is scared of opening the flap, and like be aware of opening the flap because you're gonna lose bone loss, blah. So many things happening. I said, am I the only one? Is everyone else is having this issue or just me?
Only you.
Just
kidding. Only you and me. Exactly. Only you and me. Nobody else.
Yeah.
So only you
guys.
and me. Only you and me. Yeah.
And then on the COVID, I came across an online lecture with Dr. Joseph Sherkon, and he was talking about this. So it was interesting. And then it made a lot of sense for me. Okay, now I know the myth behind this. Now I understand why it's happening. So I thought, okay, maybe nobody talk in detail about this problem and like to address it. I said, okay, let me choose this topic.
Okay.
Because from my personal perspective, that's what I faced, and I'm sharing my problem. And your problem. Everyone else is fine.
That's right. Just us.
Just us.
Yeah.
Okay. So that's the reason I chose this one because
it made such a clinical impact for you.
Exactly.
Almost a game changer.
Exactly.
Yeah.
And since then, it's changed everything and it makes a lot of sense. And I think I already posted some video in
little bit, right?
about some cases like apical suture.
That's right.
What's the reason behind this? What's the point of that?
That's right.
So maybe I need to explain why I'm doing this.
So here we go, guys. Okay, no further ado. I gotta look at this. My eyesight are so bad. Look at this. I gotta do this, right? Okay, here we go. Optimizing flap technique to mitigate oxidative stress. Okay, no further ado. Let's welcome Dr. Ahmed Keshkool for his presentation. All right, see you soon.
Hello everyone, and thank you for joining us to celebrate the 20th anniversary of Bytes Global Institute. Over the past 2 decades, Bytes Institute has been a pioneer in providing exceptional education in dental implant field. 5 years ago, I had the pleasure of joining Bytes Institute. This journey began as an exciting new chapter. Joining Bytes Institute has been nothing short of an honor, and I'm also deeply inspired by the dedication and passion of my colleagues within Bytes Institute. It was a transformative journey that not only enriched my professional life, but also improved me as a person. So, my name is Dr. Ahmed Keshkool, and today I'm going to talk about my lecture topic, which is called Optimizing Flap Techniques to Mitigate Oxidative Stress in Dental Implant Surgery. The foundation of my presentation stems from the knowledge acquired during course attending with Dr. Joseph Shokon. So we all know that blood supply to the underlying bone is coming from the soft tissue. So the soft tissue plays a key role in providing the blood supply to the underlying tissue. So how does the bone of soft tissue become ischemic? From the study of Mamato, we know that tissue either subject to excessive pressure or to excessive tension, and accordingly it will lose its vascularity. So stress is called oxidative, which means accumulation of oxidant into the tissue. From the study of Sabatsky, he found that either tension or pressure create both of them hypoxia, which may lead to the soft tissue stress or bone stress. Compression can be done by certain shape of healing abutment. From the study of Sergio Spinato, he found that reduction of biological width can be done by a certain type of healing abutment, which will lead to decrease of blood supply to the underlying bone and then bone ischemia. Another study, which is showing the situation of excessive pressure by Finelli, he placed a platform switch implant, subcrystal, and with different type of healing abutment, and we can notice that this type of healing abutment is making compression on the bone and it lead to bone loss, while the other type and style with no compression on the soft tissue and no compromise of the blood supply will keep the bone with no resorption. Tension is created by flap closure, which will lead to ischemia and oxidation. After teeth extraction, we will have some flap closure and sometimes we'll end up with tension. And after big augmentation, flap closure, most of the time, if we didn't do the enough release, we will end up with some tension and also in the short vestibule. These are all examples of tension created by flap closure. Flap management is fundamental. Tension induces two deleterious effects. It induces ischemia and flap oxidation, which will lead to delayed soft tissue healing and reduce blood supply to underlying bone. Also induce pressure on underlying bone, which will lead to bone oxidative stress. So what is the consequences of raising a flap? First, the flap gonna becomes mobile. And the second, the blood supply is gonna be interrupted. And that's all because of the mobility and the tension that we have. So after raising the flap, we need to understand the condition for the bone to recover its blood supply. And that happens when the periosteum reattaches. So the next question is, how long does it take to reattach? So according to the study of Scalfani in 2003, he found that periosteum reattach only 70% after 30 days, which means 4 weeks. And it may need 6 weeks for good reattachment. We conclude that reattachment of periosteum requires several weeks. Botros also found the same result. He found that attachment only 50% of periosteum after 12 days and 75% after 30 days, which is the same result as Scalfani. And now we know that all that time after surgery, there is permanent mobility and tension because the people keep talking, eating, smiling, coughing. All these activity is continuous, and there is permanent mobility and tension which we have to address. So what's the rule here? The rule is we like to have a tension-free flap closure. And how to assess the remaining tension? Simply by pulling on the lip or cheek after we finish our suture. But knowing that the tension is usually masked by local anesthesia, which means that the tension is more, even more, after the surgery, after the anesthesia will go away. Now we understand that tension and mobility, they must be assessed and managed during surgery. Otherwise, the consequences will be detrimental for the bone. It will work like crater on the wood. So one of the most important part is when we have tension in the vestibule, and there will be a soft tissue stress which lead to blood supply loss. And then the end result will be a buccal bone resorption, which we often see it on the buccal zone. So if we have mismanagement of tension during surgery, this tension will persist over time, and bone resorption will be an inevitable result. And that's why we always recommend that to take care of soft tissue to prevent tension, and vestibuloplasty or vestibular deepening is an effective technique to stop periimplantitis, as the study of Thoma on 2018. So we have two methods to prevent soft tissue oxidative stress. We need to prevent the tension by releasing the flap, and we need to prevent the mobility by fixing the flap. So we all know that even with the clothing, comfort is biologic, while being in a tight spot is not biologic. And the same principle could be applied to a flap closure. So the first rule is to release the flap, and to stay biologic, the flap must be over-released by at least 10 millimeter or 1 centimeter. And the second rule is the immobilization of the flap. And in order to do that, we need to have an appropriate suture technique to be used. One of them is apical mattress suture. And we can see here that this is the classic suture. While on the apical, and we call it apical because it's coming deep apical on the vestibule, on the buccal vestibule, about 1 to 1.5 centimeter. And then by this, we are fixing the periosteum to the buccal bone. So what is the apical mattress technique? On the apical mattress, we usually go from the buccal deep, like about 1 to 1.5 centimeter, and then we go out from the palatal or lingual, coming back, and as you can see, we don't need to go that deep on the buccal or lingual or palatal, and then we try to go out on the same level, and then we are trying to tie our suture. You can see that we are doing translation of the gum, and we end up with a gum bead, which is kind of excessive tissue that ending after doing the apical mattress suture. So what is the apical mattress advantage? First of all is we have a vertical ascension of periosteum. We're going to end up with gum thickening. We will have very low tension on the buccal flap. And in general, the flap immobilization and tension removal, that's the main goal. And then the end result, according to this, we will have a faster revascularization of the underlying bone. So we can see that apical mattress suture has an impact on tension and mobility. We can see the advantage and the difference between apical mattress suture and classic suture. We can see the mobility is obvious here, while in the apical mattress suture, mobility is 0 and tension is 0. Now, after we understand how to do the apical mattress, for tying the suture, I follow 2 steps. Step number 1 is to make the knot flat. And to do this, step number 2 is to roll the needle holder toward the short end always. So this is a basic video how to make the flat note and why we like to make it a flat. So basically we are following the short notes and bringing the short notes to the other end and then going back again toward the short. So this is a flat note, and you can see that flat note is staying and stay tight. And this picture of difference between flat note and not flat. So if I don't do a flat note, what will happen? Not flat note usually does not hold, and it will become loose, and you have to redo it again and again, or your assistant has to hold it. Step 2 of making the tie is rolling the needle holder toward the short end. In this video, we can see that we are following the short end all the time. So bringing this side, and now we are going back to pick the short end again and moving backward. As simply as that, to make a flat note. So sometimes, despite that we did everything right, the tension remains even after apical suture, as we can see in this video. And simply by testing after the suture, by pulling on the lip or on the cheek, that there is still tension and probably mobility. In such a scenario, what if the tension remains? Simply by bringing a blade and cutting, making a mucosal or vestibular incision to relieve the pressure and the tension from the flap, simply by injecting some lidocaine with epinephrine 150 before the incision, just to minimize the bleeding that may happen after. So what is the vestibular incision advantage? It has the reduction of flap tension, which is the main goal. No postoperative pain. As I said, pain usually is coming from ischemia, so we are reducing the tension. No PRF needed to cover the incision. And most of the time there is no bleeding, because especially when we inject the Lido with 150 before the procedure. So it's very there is so many advantage and no disadvantage in this procedure. So now we know that the main question is when to remove the suture and what type of suture to use after making all these procedures. Now we can go back to the study of Scalfani, and that we know that periosteum have the reattachment of 70% after 4 weeks or that. So at least periosteum need to stay 4 weeks, and the suture must stay for at least 4 weeks. So now we know the duration that we need to keep our suture. So we all know that monofilament type of suture is our preferred suture in dental implant field. And we have the resorbable and the non-absorbable. So for example, we have the nylon and the PTFE. But these are inconvenient because if we leave them for 4 weeks, the threads are covered by the gum, embedded, and therefore it's very difficult and painful to remove after 4 weeks. While the resorbable type of monofilament, which is the glycolon or monoglyc, they have the ideal absorption time, which is 4 weeks, which is basically, that's the minimum week. The 3 common glycolon suture size that being used in dental implant field is the 40, which resorbs in 5 weeks, the 50, which resorbs in 4 weeks, this is the most we use, and the 60, which resorbs in 3 weeks. So the advantage of glycolon and monoglyc sutures are they are elastic, they have stable nodes, no need to move them, no pluck, sufficient time for periosteal reattachment, and significantly reduce the risk of suture disunion. At the end, if I need to define myself, I'm a dentist who loves to empower smiles and transforming life with passion. Thank you.
Thank you. Thank you. Good presentation. I know you made this present just for me.
Yeah, just me and you.
Just me and you.
We are the only one that have a problem.
The problem.
It's not about you guys. Don't listen.
Well, you know what? Sometimes it's the elephant in the room, isn't it? Nobody want to talk about some of the failures that we have. And we all know everybody has them, but nobody wants to talk about in one of those situations. Yeah. So, it was really nice that you explained to us the cause and effect of the flap and all that. So basically, correct me if I'm wrong, the whole purpose of this is the releasing and everything, and the way you position the entry and the creating is to basically reduce the tension that will be applied after a traditional flap closure with the muscle and all that pull.
Yeah.
So by is taking the tension away from the incision line, you're taking that tension to the apical area, so that when you have it, the tension on the tissue, soft tissue, is passive. Is that the whole point?
So I'm releasing the stress here. So I'm releasing the stress on the flap because, as I said, even with the clothing, like in the comfort zone, you are biologic. So that bone graft, you don't need to put tension or like ischemia during the flap closure. So make it like simple and relax. That's why we over-release it. And now the other tackle, like the problem, we have the tension, which is the muscle pull, which is coming mostly from the lip and cheek. And some may ask, what about buccal veneer graft? No, I'm not talking about this because we didn't over-release. I'm talking about a big flap, big GBR that we always face, me and you face. Okay? So this is kind of the lecture about big flap.
Okay, gotcha.
So not the small like one because I'm not releasing the muscle.
So this is more like a large sausage technique, large vertical reach technique, large Santa technique, and things like that, where you really want to do your due diligence so that the wound doesn't open up.
Exactly.
Right.
Like we just teach in the morning, like what is the guided surgery? So we need to open that just small crestal incision just to look on the bone, and then we just suture it back. So that don't apply for it because we didn't over-release. We didn't lose the attachment of the periosteum. We still have it. Okay? Yeah, but that's about the big flap when you open it. And this is the problem we always face because of these two fundamental factors. We need to address them.
That's right.
Stress and the tension.
Wonderful. Wonderful. Now we got some questions happening here. And we can always count on Bernard to ask questions.
Oh, yeah?
Yeah, because let me see here. Never knew apical mattress, never internal compression suture. I always did internal compression suture. Apical mattress can really stabilize outer apical tissue. I think the internal compression and apical suture, I think it's very similar. I think the difference is where you create that tension, apical versus horizontal. I think that's the only real difference there. Bernard asked question on everybody's behalf. Okay, he says apical suture, does it result in vestibular loss due to the flap coronal advancement?
Yes.
Yeah, that's one of the common side effect, isn't it? Every big GBR that I do, I have to follow up with an FGG, vestibular deepening. You know.
And that's why I mentioned also because you need to relieve that tension right away. I know we're going to do that sulcus deepening or later on, but till that time, you have this deleterious effect on your bone graft, on your implant. So to release that, I will just bring a scalpel, bend a new one, always. No, don't use the overuse. And then give that injection. Usually I give it 5 minutes before. The epi with 150.
That's right.
And then I just cut. And sometimes you said, oh yeah, that's going to end up with a bleeding. Trust me, no bleeding. And always the patient come, do you have a bleeding? No. Do you have pain? No, because we relieve that. There is no ischemia. So the pain comes from ischemia. They will have the swelling, that's fine.
They'll have swelling, okay. For sure. And they'll have swelling, they will have bruising, especially my geriatric patient, they'll definitely have that. And I think this is a very important point. I think a lot of the doctors, including myself in my younger years, I will do these big cases, and I'll do all that. But the problem is, I never follow up with gum grafting or vestibular deepening. So it's almost like goes hand in hand, you know. What we need to do, what I do nowadays is, if I'm doing any a significant lateral wall or vertical ridge augmentation, I always include a treatment plan later on, once everything heals up, to vestibular deepening and FGG.
Yeah,
right?
because we need it.
We need vestibule.
Yeah.
That's one of the things that my mentor Mish always started. Why would you need a vestibule? They're not teeth. They're only implant. You don't need vestibule. Well, later on, he begged to differ. We eat our own crow, right? What we believe, we later clinically to be not true, and we come to realize that implant teeth, especially posterior, we need more vestibule than ever before, right? Especially what I find with a lot of my older All-NX cases, because I chopped up the bone, and my vestibule is gone, and then it's all muscle there, right? Everything is pulling. I'm losing my implant, so I know that vestibular deepening is very, very important. That's why FGG is more preferred over CTG, because CTG cannot give you vestibular deepening, but the FGG will, right? And it's a simpler procedure. So that's a very good question. Thanks for the answer. How far apart do you place your apical mattress sutures? Is there a formula, or is it something that
as I mentioned, it is 1 to 1.5 centimeter. I go down like apically, and the space between my entry point and the outer point is kind of, I will say, 4 to 5 millimeters, in that range. So,
and you'll do multiple of them. Depending on the
at least you need, depending on the site, but at least you need to support it with 2 or 3 or 4 of them to support that.
That's right. Because you want even tension. Once again, you don't want one and then the loose on the other. You want to put it up. So these suturing, they take time. They absolutely take time. And I always remember Albert Louis says, from one of his mentor, Urban Sausage Man. The Sausage Man always said the reason your GBR fail. It's because you rush the first 5 minutes and you rush the last 10 minutes. And it's so true. It's so true, right? Yeah. Because what makes a successful soft tissue management? Doesn't matter how much of a membrane or bone tech or all that you put in there, if you don't manage the tension.
Now, one more important thing I didn't mention is that you need a flap closure. So you relieve the tension with this apical suture, and now on the top, you need to make sure that you're tying suture on the crest of that opening. It kind of don't make it very tight. Loose enough, like as tight as enough, as loose as enough.
But not a tension tight.
Exactly. Don't go with tissue blanching.
Especially, which is easy to do if you're not careful with the 5-glycon. These are monofilament, and they create tension real fast. So they're not like a PTFE where you overstretch it, it stretches out. Glycon don't stretch out, man.
It will stay.
It
will stay.
And if you leave it like that, it will cut like a butter right through it 2 weeks later. So that's a very good point. Thank you very much. I
ask my assistant sometimes to put the scissor. And then I tie on top of it.
Just to make sure that it's gotcha. After we have a Dr. Jedi S. After making the vestibular incision to relieve the tension, I think referring to the last part, do you suture that back, or do you leave that area as is?
Absolutely no. Just leave it as is.
Because what you've done is a partial thickness from the outside, isn't it?
Exactly.
Right?
So I'm just removing the tension. And then, as we discussed, doing FGG, it's kind of an eventual event for us because we need to go with the sulcus deepening. Till that time, we need to move that tension effect. So I don't put suture, I don't put PRF.
It's important though. I do need to clarify this here. When we're doing tension relieving, like Dr. Keshkool showed, you're relieving the periosteum, get the stretch. So when you're relieving that tension from the outside, you don't want to make sure that it's not the same area. Because you end up with the holes in there. Right. So please do be mindful when you're doing this.
So to do this, while you're pulling, it's the same that when we do the partial thickness. So you're pulling the tension and then you cut. Is that right? So it's when you pull, you know where's the tension, and you just move your scalpel there. Just relieve it.
Just be mindful of the level. Because you don't want to end up with the dangling thing, end up suturing all over the place, right?
Don't go deep.
Don't go deep. Don't go deep. That's very good. very good. Yeah. Yes, eversion can equalize the tension. Yeah. What I find the perfect match in heaven will be use the apical suturing to relieve the tension. And once you get the loose thing, then you start to do an eversion to get inside ends meet, right? Yeah. And so when I do this type of a surgery, I find is if I book an hour or hour and a half, actually the part that where I bone tack and everything, it takes me less than 10 minutes. Where I spend most of the time suturing is I spend good 30 minutes the suturing part.
Suture.
And I'm a pretty speedy suture, but even for me, I want to get everything lined up properly and everything tension free, and you have to pass all the tests and everything, because otherwise, 2 weeks later, I'll get a volcano effect.
Yeah.
Which everybody nightmare. Okay, and you know.
Just me and you.
Just me and me.
Yeah.
And I got to take a photo of all the post-op, but I don't want to take that photo. It hurts to look at, but I got to take it, right? Because it's a reminder then for me to do the better job next time, right? Yeah, absolutely. Okay, very, very good. Excellent. Okay, yeah, even if it's your good question. How far to place it here? Good, excellent. Okay. Yeah, good for the vessel incision. That's it. Yeah. So with this technique, what would you say for a beginner? What's the common mistake whenever they're trying to apply this technique? What are the tips that you can give? Certain instruments, something, like I get that question a lot. What instruments should we use for a particular procedure like this over here?
So one of the main tackle for beginners is the flap release.
Yeah.
And we all struggle. So we need to know our limits. So many of us know that like periosteal release with our scalpel.
Yeah.
Me, I use both ways, either with scalpel or sometimes I use a brushing technique, soft brushing.
Yeah.
It kind of, usually I use the brushing technique close to the mental foramen.
Yes.
And to avoid.
Just for safety.
For safety, it's way easier and it's like just to be on the safe side.
That's right.
And I found it give me good release, but I end up most of the time I have to do release of my flap with the periosteal like release. So once you get that, the 10 millimeter rule, then just follow the steps.
That's right.
The suture, and then it's just need to practice.
Yeah.
You just need to practice.
Yeah.
I'm not inventing this. This is science.
That's right.
Everyone is talking about this. So yeah, it's just a method of releasing. So many methods. So someone said, okay, maybe we can use this is not a new, this is a deep matter suture. I know, exactly, but we just need to work on this. And the difference with the apical matter suture, that's a version of a flap that we get extra tissue, which give us some relief of the stress, okay? And the tension, because I move it up, most of the time I'm gonna end up with tension because I'm pulling.
That's right.
Yeah.
That's right.
So when I pull, I end up with kind of releasing of that, like the tension from the muscle mobility.
Especially when you're working on the lower anterior, it is really, really important to get the muscle tension away. And also when you're doing a vertical ridge augmentation on the posterior, when you're releasing the lingual part, make sure you don't go beyond the malohyoid. And there are a lot of vessels there, and you don't want to hit something that you cannot control the bleeding. So I think using a blunt dissection in those special areas is important. And the muscle, they always want to reattach back the mentalis here because all the motion goes over there. And those areas, make sure we follow up with the vestibular deepening. Okay, that's something that we just have to. A lot of us general dentists, when we're first going into like a GBR, we always face failures, and because we know how to place implants, but the soft tissue management is almost like an afterthought, and that's something that at Bison we try to encourage doctors to go into soft tissue management, rather in the early career rather than 10 years later.
Yeah.
Okay, because that's a mistake that I made as a general dentist when I was venturing into this journey, right? Yeah, that's great. It's a 750. That's almost Yeah, I think Bernard asked one question. I think he knows all the answers, but he's asking on the behalf here. Okay, thanks, Bernard. Are there anatomical limitations using apical suture? Anatomical limitation, example, limit floor of the mouth, anterior floor of the mouth. Yeah. I mean, I guess there's always going to be some limitation because you cannot go beyond.
Yeah.
Right. If they got such an atrophic, right, muscle. But in those situations, do we really need to do a bone grafting vertical? It's so atrophic anyways. Typical, then those are like Olonex cases. In any situation, if there's such a big discrepancy, I find the hardest bone grafting for me to do in my career, and I'm always going to have a struggle, is a significant mandibular anterior resorption. Yeah. Opposed to the adjacent, areas high up.
Yeah.
And I need to create a vertical bone height mandibular, like half an inch. I don't think I'm going to be successful.
Yeah.
So
because of the quality or the type of the bone there.
Type of the bone. Also
muscle pull,
everything goes against that.
And muscle pull from both sides, lingual and facial.
Yeah, tongue and there. Yeah. And there's some of those things I don't try to be a hero because I've done enough of those cases. I know what my odds are.
Yeah.
Right? And some people will show those cases with certain technique. I don't buy it because I have some successful cases, but they're too far and rare in between. Yeah. And I'll be honest and realistic as possible. You got to get lucky.
Yeah.
Okay? And the muscle has to be in the right way. Even with you do all the proper control and everything, certain areas going to have a lot more limitation than others. Yeah. Right? And also ability to heal. My patients are not going to heal well. They're geriatric. 75 to 80-year-old woman or man to heal after in those areas particularly. You're asking a lot, right? Yeah. So I think it's always a risk and benefit whenever we try to come up with treatment options, right? I want to thank everybody. I think David, for doctors who are joining us live, let's give them AGD credit code. Here you go. Verification code. BITES 20 AK flap. Okay, let's decode that. BITES Institute, BITES 20 anniversary, AK Ahmed Keshkool flap.
Yeah.
There you go.
My last name.
There you go. BITES 20 AK flap. So type that in for your submit for the AGD credit, and you will get your 1 AGD CE credit. So thank you everybody for joining live, and Ahmed, thank you so much
It's my honor.
for joining and keeping us a pearl or two once again.
Yeah.
Right. Next time will be vitamin D, right?
Okay.
Yeah, but you're the vitamin D guy, right? Yeah. Because the story is that he was originally preparing a lecture for vitamin D because he's also a firm believer in the vitamin D, and so am I. Okay. So let's re-invite him back someday to have a short mini lecture on vitamin D and how he implements to his patient and prescription and the dose and everything to hedge our bet a little bit more to our way to win a little more than lose.
Exactly.
Right? Okay, so we'll do that. Once again, everybody, thank you so much. Dr. Ahmed Keshkool, wonderful. Okay, we wish you a safe trip back home as well. Thank you.
Thank you so much for having me. Thank you.
Okay, guys, take care.
Bye.
Bye-bye.